Thank you, Florian. It's so exciting for me to be here today to talk about cellular therapy for cerebral ALD. And just my disclosures, I am a pediatric stem cell transplanter. I'm not a neurologist, but I've been working with Florian now, I think, for, gosh, somewhere between 5 and 10 years transplanting boys with cerebral ALD. It's so interesting to hear that you've had a stem cell transplant as an adult. I didn't touch on that piece today, but we'll be certainly looking forward to talking with you a little bit more about that piece of things. So what I hope to do is just to give you an update on the status of cellular therapy when it comes to cerebral ALD, focusing, and when I talk about cellular therapy, what I'm talking about is stem cell transplant or bone marrow transplant and gene therapy. So I want to talk about the differences where we've come and some of the recent long-term outcomes data. So things we'll do, so I want to review the general principles and processes of stem cell transplant and gene therapy. I know some of you are probably very familiar with those things and others in the room are not. So bear with me as I go through some of those basics. I'm going to discuss the neurocognitive and the functional outcomes in children who are long-term survivors of cellular therapy for what we know now, and highlight some of the differences between allogeneic transplant and gene therapy, and then talk about some future directions. So with cellular therapy right now, this is the only non-research therapy for cerebral ALD in children that has been shown to preserve neurologic function. And there are some basic concepts about transplant to know and its efficacy in that we're unable to reverse changes in the neurologic function that have already happened, but what our goal is to try and preserve the function and prevent progression to more deterioration. We've been doing transplants or allogeneic or bone marrow transplants since 1988 for boys with cerebral ALD. And even though that's been a seemingly long time, we still represent a very small portion of the stem cell transplant population in the United States. So of all the transplants performed in the United States each year, less than 0.3% of those are for ALD. And that has to do with a rare disease population, but also trying to identify patients at a time when transplant or other cellular therapy is appropriate. But things are changing. Oops. So sorry, I'm not sure my pointer's working. I'm sorry. So thinking about where we've come with stem cell transplant and gene therapy. So in 2011, there were 22 patients transplanted in the United States for ALD. That number has gone up or shifted a little bit over time. In 2015, we see growth in that number, so 23, so not huge changes. But what the key difference in this slide is the autologous stem cell transplant patients. So allogeneic transplant means you're getting bone marrow or stem cells from another person. Autologous means we're using your own stem cells and giving those back to you. And the column of autologous on the left, that is entirely represented by gene therapy patients. There's no other way to do auto transplant for ALD. So that has been a massive shift in the landscape and represents a huge portion of the patients who are actually having cellular therapy in this country. One of the things that I'm often asked either when speaking with families, with other stem cell transplanters or other providers is why on earth does this work? A stem cell transplant is a blood treatment. We are taking blood-forming cells from a person and giving them to another person. And so why would that at all work for ALD? And there are mechanisms, proposed mechanisms, but the truth is we have ideas about why this works, but very few people in this world could probably tell you exactly what the mechanism is, but I'll tell you what we think is happening. So what we think happens is that we're replacing the patient, the host's microglial cells, by donor-derived cells in the myelomonocytic line, and I'll talk about that in just a second. But we are changing the cells that migrate into the central nervous system. That can then alter the inflammatory environment and the immunologic reactions that contribute to the disease. So Florian was talking just a few moments ago about inflammation and the roles of microglia in inflammation. Well, in stem cell transplant, we're trying to change those cells, the microglial cells, that are perhaps contributing to the inflammation. So I know there are a lot of neurologists in the room, so this is a stem cell transplanter's view of microglia, so apologies and forgiveness is asked. So what are the good things that the microglia are doing? Healthy, functioning microglia. So we are altering the inflammatory environment by releasing the number of growth factors. You're triggering some stimulation of stem cell derived factors that help to repair damage that is already there, and the clearing up some of the debris that's the debris that is there from unhealthy or pathologic processes. So the microglia in the brain are changing the inflammation, or they're modulating the inflammation. And so those exact mechanisms we're trying to figure out. So that's great, but why does a blood transplant help you? So the top portion of this represents the cells that we are transplanting. So on the far side is a stem cell. So you'll hear people talk about stem cell transplant, bone marrow transplant, sort of what's the difference? They're all stem cell transplants. A bone marrow transplant means you've got your stem cells from the bones. Cord blood transplant means you're getting your stem cells from the umbilical cord blood. So it's all about location. So I'm not going to go through every cell on that slide, but on the far end are the cells that come from a stem cell. So a stem cell can turn into every single blood-forming cell in the human body. So the stem cell can turn into the cells of the immune system, the platelets that help you clot when you're bleeding. They can turn into the cells, your red blood cells. And here's the thing, they can turn into cells called macrophages, who along this macrophage monocytic line turn into microglial cells and can differentiate. So by giving a blood cell, we are giving cells that ultimately can turn into cells that can modulate the environment and the inflammatory environment in the brain. So that's why we think this works. So here's the next point. So that's great, but does it actually work? And so this is what happens for a patient or a boy who's going to transplant for cerebral ALD. So first, they have to have some evidence of disease progression. Stem cell transplant is a highly risky process, or a treatment option, and we don't want to take people to transplant who don't absolutely need a transplant. All allogeneic transplants in this country are associated with approximately a 10% chance of dying by day 100 after transplant. For boys with ALD, that number is much lower, but it's not zero. And so for children, also much lower, but again, not zero. So you have to need to go. So then the next piece is that we identify someone to give you cells. So this is the allogeneic transplant. We're going to find someone who doesn't have ALD, go into their bones, get their marrow out, and give it to you. So we have to find someone to do that. Ideally, patients would have someone in their family, so usually a brother or a sister who's unaffected by disease who can donate bone marrow to that person. If you don't have a person in the family who can do that, we do what's called an unrelated donor search. There is a worldwide connected database of over 36 million people who can serve as donors or who are willing to serve as donors. So that's great for a lot of people. But what this slide shows you, and I know you can't read it, so I'm just going to walk you through it, the problem or the challenges we have in that the very top line that's far well above it, that curve represents patients who have white European ancestry or background. So that means on this slide, we have about a 75% chance of finding a good donor from someone of that background. As you go down further, we have a much harder time finding donors. And so the very bottom line are patients who are either of African or Black, South, or Central American ancestry, where instead of that 25% chance of finding a donor, it's less than 10%. So we have a lot of work to do. So finding a donor is something that can be a challenge for patients. And with boys with cerebral ALD, we don't have all the time in the world. We don't want to take 6 months to try and find a donor and then find out that we can't. So that's an area where we need to work on and improve. So what happens next is the boys go through all sorts of testing to make sure their organ function is good, and they get admitted for transplant. They get about 10 days of a chemotherapy regimen, and this is chemotherapy the same as you would get if you had leukemia. And so why do we give boys who don't have cancer chemotherapy? In this case, the primary objective is to make space. So we want to make space for the new cells coming in. We also want to get rid of the cells from the person who's getting the transplant, their ability to reject them. So we want to make an environment where the cells can come in. I've heard people talk about it as though, and then I get lost in the sort of the analogies, if you're farming, and so you're tilling the soil, and if you've got a whole cornfield full of corn, other cells aren't coming in there. If we are about to plant the corn, what we're doing is getting rid of everything that was there before, cells coming in, have space to grow and to develop. So that's what we're trying to do. They're in the hospital, they get the infusion. It is given like a blood transfusion. That, the whole process is probably the least dramatic piece of it. And then the counts recover over 3 to 4 weeks. And we hope that the signs and symptoms, either radiographically or clinically, certainly plateau in the next 3 to 6 months. And so it's probably another important thing to know is that the disease can still progress in some cases for up to 2 years after cellular therapy. And so we want to identify patients as early as possible to try and preserve as much function as possible. So does it work? Yes, it does work for many patients. So the top line and the blue line represents patients who have very early stages of cerebral ALD. So we've seen evidence of progression on MRI, but they are very early, have less scores, lower than 9 in this particular study. The boys on the top are the boys who are transplanted, and that's a 95% survival compared to untransplanted boys, which obviously that continues to drop over time. Other studies, and this is a good study, and Florian was mentioning in his presentation, that came out of the University of Minnesota, show a little bit more of a sober number. So rather than 95%, we see a 75% survival. And that has in large part to do with who goes to transplant. And so transplant, again, is only effective if you have early stage disease. So in the top line are boys who had less scores lower than 10. And then the bottom line are those who have scores greater than 10. So for advanced cerebral disease, cellular therapy is still not an effective treatment and an area that we need to talk about how to work on, which is so exciting to hear some companies focus on advanced cerebral ALD, and I would love to try and partner that with transplant if possible. It's not just the MRI scoring, but your neurologic functional deficits. We see the same results. So if your neurologic scores and your function is high, you often do well after transplant. If not, quite the opposite. And that highlights that point again. So the key things to know from this is that it is effective for boys who have early stage disease for whom we can find donors. So they're effective, but lots of caveats that come after that. This is a study that came out this summer, and it's interesting to me because it talks about patients who survived transplant in childhood. So these are boys who are transplanted in childhood who are now adults, and what is going on in their lives. And what it is showing you again is that difference, and again, I know it's difficult to read, there are differences in how well you function based on your scores even 10, 20, 30 years after transplant, but also that things still aren't perfect. So the scores on the top are showing you that boys who are now adults still have issues with verbal comprehension, reasoning, working memory. So there's still a lot of things that are not normal after transplant, and we need to figure out how to do a better job preserving function. Looking at quality of life is a similar story in that we see boys who survive into adulthood still reporting problems with physical functioning and chronic health issues. So in this study, they show that 38% of boys who are now adults who've survived transplant have decrements or problems with their physical functioning. They also, and I think this is the part that is a little bit humbling and sobering to me, is that they're reporting higher rates of sleep disorders, anxiety, depression, and hostility in some cases. And so this is information that we need to figure out, and this is new. For the first time, we're able to see boys who are now young men or adults who've survived transplant, and are trying to see the problems that still exist afterwards. And so there's a lot to be explored in that area. The other thing to know is that some of these numbers are not significantly different than patients who've had transplant for other reasons. And so what I've hopefully from that piece I've shown you is that cellular therapy or gene stem cell transplant is effective, but there are still a lot of things we need to do. And so one way that this is being addressed is through gene therapy. And so thanks to Gary and the team at Bluebird for helping with these slides and for partnering with us for now so many years to try to move this to a reality. And so just to walk you through the process of gene therapy, so the patient's own stem cells, so rather than getting bone marrow or stem cells from someone else, we're collecting them from that patient. So that patient, this is obviously not a 6-year-old boy who's getting their stem cells collected. Probably you can tell because they're so still and you could get them captured in a picture. So the boys are connected to a machine that looks very similar to this, where their stem cells are collected. Blood is similar to dialysis. Blood is separated into stem cell components and non-stem cell components, and the rest is returned to the body. Those cells have the gene, a corrected ABCD1 gene inserted into their DNA. And that is done by a virus. And this is, I think, one of those amazing things about science, is that the virus that we're using is derived from HIV. And so we are taking the bad things, the infectious piece, all of those pieces away from it, and harnessing the parts of HIV that can actually get into the DNA and get into the human genome, and that is so exciting. So we're getting rid of the bad part of it and taking this horrible virus and using it for something very good, and in this case, to insert the gene into those stem cells. And it's much more complicated than that picture, I'm sure, but in my mind, that's how it happens in a lab away from the patients. So that viral vector is carrying the function gene into the blood stem cell, and so that gets inserted. And then there's the magic. We all don't have lights inside of our DNA, but if you did, it would look like this. And so the virus inserts the genes permanently into the stem cells, so that patient's DNA now have a fully corrected gene inserted, which is pretty amazing, in my opinion. So then a couple of steps are skipped over here and that are worth highlighting. The patients that go through then the stem cell transplant process very similarly to boys who are getting from somewhere else. You still get chemotherapy. At this stage, it is still the exact same chemotherapy that is given to whether you're having stem cells from another person or in gene therapy. You have a central line, which is sort of a longer permanent IV inserted, and go into the hospital, and it is administered looking pretty much just like this. So it goes in over 20 minutes. Start to finish, 20 minutes, that's all. At that point, the stem cells go in, they get into the brain, and this is that part again. So those monocytes and macrophages differentiate into brain microglia, and that takes time. We're starting in bones, the cells have to reproduce, they have to multiply, and then they have to get into the brain. So I asked the question before about stem cell transplant, allogeneic, and does it work? And the answer at that point was yes, with some issues. And so the question, does gene therapy work? This seems amazing. And the answer is, I guess, I'm not sure the exact right way, Gary, to say this, but a cautious yes. And so we think that this is working, and so one of the things that we are incredibly proud of from this trial is that the paper was published reporting the outcomes of the first 17 boys in this trial in the New England Journal of Medicine in October. And so this has been accepted by the community, and the results were published. And I'm sure, I don't know, Florian, if you brought a suitcase of them with you everywhere you go to share the paper, but it is out. So just a few highlights from that paper and the results. So there's 17 boys who were treated. So in this paper, there more have been treated since. We followed up over, the median follow-up is over 2 years. So at this point of reporting, close to 30 months. All of the boys in this study had measurable ALD protein in the cell. So one of the things we were looking for is, obviously the boys, where we can tell things about them clinically, but we do studies to look and see how much of that ALD protein is being expressed in the patients, and it is in these cases. There were no treatment-related deaths, which is important because we talk about the intensity of stem cell transplant, and we're hoping that gene therapy is a safer alternative. So no deaths in this study due to treatment. 15 of the patients were alive. There was one death due to disease progression, and then there was another child who had advanced disease who went on to a stem cell transplant, an allogeneic from someone else shortly thereafter, and died of complications of that stem cell transplant. So there were some deaths. Those numbers are roughly similar to what you would expect from allogeneic transplant as well. On the far side of the slide, the top square is looking at the neurologic functioning score, so lower is better of the boys in the time since transplant. And so the important thing is at the very bottom line of score of the neurologic function score of 0, 12 of the boys in the study are there. So 12 of those boys have had no significant neurologic change or progression of their disease. And then you can see some of the boys, so 4 of the boys have had some minor change, and then the child who progressed having the much more advanced changes. In the most recent clinical status in the bottom, so the bottom square is talking about something called the vector copy number, which tells us about the success of the actual transduction and getting that gene in. We look and see that on the far side, most of the boys had no change in their neurologic function at all. So it's very important to know, obviously, go ahead. Oh, I'm so sorry.
How old is the oldest boy in the study?
At the time of transplant or the treatment or now?
Currently.
So he is, and so at this point in time, I'm close, I could be a little bit off, he's probably between 11 and 12 right now. The oldest boy, who happened to also be one of the very early or when the original boy is treated. There are boys after that time who may be a little bit older, but no one is into teenage years yet.
So it'll be really interesting once these boys enter adulthood.
Absolutely.
It's going to be very, very interesting.
Absolutely. And one of the things about gene therapy trials in the United States due to regulations is that you're mandated to follow boys for 15 years, or for anyone who has gene therapy for 15 years. So 15 years doesn't get us far enough probably into adulthood to know. It's interesting, but you will want to learn further. The families in these trials are very dedicated to research, and so I do suspect that if we want to follow them 20 years from now, 30 years from now, that would be an option. But absolutely, it's going to be really interesting to see. So the study, we started enrolling boys, the first boy was in 2014? No. Okay, so it's been a while, so we still have a ways to go. And thank you to Gary for the slide. So it's a really great summary of where we are. So the eligibility for a trial I didn't touch on. Boys have to be less than 17 years of age. You have to have evidence of early cerebral disease and have no matched sibling available. So for boys who have a donor who is a sibling, those patients are not eligible because the outcomes are at this point so good for those boys. The primary endpoints, we're looking at the percentage of boys who are free of major functional disabilities at 24 months after treatment, and those who experience graft versus host disease, which is the most common and quite severe complication of stem cell transplant at 24 months. None of the boys in this trial experienced that. And so just on the bottom, so since January 2017, 4 more boys have enrolled on the trial, and we have some boys who are getting close to that stage right now. Just in the interest of time, I'm not going to highlight all of this, but these are just the differences between allo and transplant and gene therapy. So the donor is different, obviously, it's yourself or it's someone else. And then jumping down to the very bottom part, things we really need to work on. So graft versus host disease is when the new immune system from that person in bone marrow transplant attacks the person who got it. That's not an issue with gene therapy. That is a significant issue following stem cell transplant from an unrelated donor. And where we do need to work on, since both treatment options use busulfan and cyclophosphamide, which are very highly intense chemotherapy regimens, there is still a risk for long-term function, organ dysfunction, not related to ALD, so long-term cardiac, liver, other issues. And the regimen that we use makes all of these boys infertile, so it affects sperm production to the point that we would not expect these boys to have children as adults. So we really do need to work on that. And so what's next and what do we need to do? So the gene therapy trial is enrolling. We're continuing to work towards that with the ultimate goal for Bluebird to have this approved by the FDA, so not on trial. So anyone can, and boys who have early stage disease could get this as a treatment, not on a clinical trial. From the transplant side, we're trying to learn more about using different donors. So there's something called a haploidentical transplant where the donor is a half match. And so in these cases, it would typically be a sibling or a father. In that case, the reason you'd want to use that half match is you can go really quickly. If someone's in your family, you can move from the time you identify that patient to transplant in a period of 2 weeks, 3 weeks if you have a matched family member. And so we're working on ways to make haploidentical transplants safer. And then investigating reduced intensity transplant regimens. We don't want to give boys with ALD the same chemotherapy that we're giving people with cancer. We need to find ways to do that safer, that eliminates the long-term toxicities or decreases the long-term toxicities, and we need to do those things. And the other areas up there, just that I didn't mention we need to do is sort of think about more about transplanting adults with cerebral ALD, because that's not been done as commonly, so how to do that and how to do that safely, and then also how to support to develop neuroprotective strategies during transplants. So N-acetylcysteine is used. Are there other drugs, these drugs in development, that can be used at the same time to try and create a more neuroprotective environment during transplant? And I just really want to thank Floria and the teams, the stem cell transplant gene therapy teams at Mass General and other places, and certainly all of the patients and the families who have made this work possible. So thank you very much. I think, Florian, I think, are we too tight on time for questions, Florian?
We're a little tight on time, but I do want to allow people to ask 1 or 2 questions.
My question is, do you foresee a time in the future where this will be available to cerebrally asymptomatic boys?
I would like that option to exist, but I think right now transplant is still too dangerous and too intense. So The survival after transplant is actually quite good for boys with ALD in the modern era when we've identified good donors and we can do those pieces, but still the long-term toxicities are significant. And so I think at this point where we know that not all boys are going to progress to cerebral form, it's really, it'd be hard for us to take someone and put them through that level of transplant toxicity. If transplant was safer, and we're working on that, there are lots of sort of areas then perhaps, but not right now.
And maybe just to add to that, we still think that the mechanism through which this works hinges on the open blood-brain barrier and the inflammation that's actually occurring. So how, in a pre-symptomatic child who doesn't have a lesion, what would this treatment be doing is still an open question. Right?
That's a good point.